carbon in the air, so the pollution is higher. On the other hand, legalization has also increased the revenues and generally reduced the arrest of cannabis possession. At one time, in the 90s, the Prime Minister of UK, Tony Blair, he had the famous English statement: decriminalization, but not legalization. If you have an interpretation of this two wording, actually these two wording are governing the world up till now. Decriminalization, but not legalization. So he is not putting the people whose possession of cannabis in jail, but it's not legal. So where they should go? That is pretty ongoing questions. Now, the requirement priorities of population of substance use disorder or drug use disorder. The present time, it is worldwide difficult to identify a country in which a very comprehensive treatment management is there, at the ideal of your brain. Very, very difficult. For reasons, policymakers and healthcare leaders are forced to prioritize which population receive the attention, for what problem, in what location service system can be, and using which treatment modalities. So these are the four cardinal questions that hopefully in the coming few slides, to remind myself about the new classification or the new classes of psychoactive substances included in the ICD-11 and the revision of the ICD-11 and their main categories and subgrouping. So please, these are what the UNODC is working at in its tables, and also the WHO how it now look at substance abuse. Still, medical colleagues who said, oh, this is a soft drug, this is a hard drug. I haven't heard this terminology in our profession for decades, but they are still using it, allowing some medication and denying others. But these are the categories. Now, to deliver the treatment to answer the four priorities, to who? Adults or adolescents? Prisoners? Pregnant women? Students? When I said adults, I mean men and women. But when I say pregnant women, this is a very specific, excuse me لو سمحت، مشكلة في الشاشات. This is very crucial because pregnant women have special settings rather than women or adolescents. And what drug that we are going to service for? Drug, alcohol, behavioral addictions. Yesterday I asked Professor Potenza, do we have guidelines? No guidelines for treatment yet. They are working on it. I can tell you center in Switzerland, Geneva University, center in Belgium, center in Japan, in Yokohama in specific, center of course in China, centers in China, and Shanghai University, Shanghai University, they are all working hard and they are trying to help each other to develop the guidelines, but still not yet released. Should we treat people in the primary health care, mental health services, special addiction clinics or welfare centers? Each and every country, you will find bits and pieces of that. But then, how can we integrate How can we reach a service that can really benefit our patients? And then how to treat them? By screening and brief intervention, 7 to 14 minutes session, by opioid-assisted treatment or medication. Some of our countries have it, some are not. By behavioral therapies, or combined approaches, or maybe there are new approaches for that. So the triple, or the four also questions here are crucial to look at. The strategies over the world are still the same, but the content of management of these strategies are different. So the supply reduction strategy, it's all political and for the law enforcement to deal with. But the demand and harm reduction that ICU-DDR and also ICU-DDR is working with that but the demand and the harm reduction were prevention and education. Partly our university here have our role in that, and I was just discussing with Professor Whaley regarding how to update our educational channels in order to be able to deliver to our new house officers how many of them, 150 or 200, 240, they are every 2 months, 240 postgraduate senior house officers in the department, 2 months. So how we can address this? Reducing medical, psychiatric, or social sequelae, complication, screening and brief intervention for the treatment, or organize the application and use the AI empirically up to now. Now, before going to the key principles for the treatment, the substance use disorder can be effectively treated using a range of pharmacological and psychosocial intervention. The aim is to stop or reduce the use, improve health quality and the quality of living, and prevent future intake or relapses. But many interventions that we all know do not meet accepted scientific standards or criteria and efficiency. Such intervention may be ineffective or even harmful. This is not my word. This is the WHO and the MIC. So as if they are looking to our current situation in our country and in our continent, and perhaps all over the world. So, what are the key principles? Number one, treatment should be available, accessible. Yesterday, it was a talk about accessibility of the treatment. In a remote or a shanty area, in any country, people there should have access to treatment. This treatment might not be the faculty here or kasr AlAiny, but could be the primary health care services there. It depends on the health system at each and every country, so that everybody have the access to treatment. Promote treatment for drug use disorder through effective coordination between the criminal justice system and the health system and the social system. This is crucial. We should not contradict our efforts. We should integrate our efforts. Treatment should be based on scientific basis, as much as we are going to see now, responding to special treatment and care needs population groups. Again, we are going to see what we do mean by the multidisciplinary teamwork, how we can quantify and calculate this. Ensuring good clinical governance, policy and procedures. At the hospital in kasr AlAiny, there should be, everyone should know what to do, how to do it, and what not to do it, and how to refer and how to report. This is, and then there are audits, internal audit and external audit, and Dr. Ola can talk more than me regarding the quality and the audit. The treatment services, policies and procedures should support an integrated treatment, not a segregated treatment, as we will see right now. So these are the 7 key principles. Lots of description in the texts that I showed you at the beginning. So how to develop a competent workforce? This is a slide needs a bit of your attention. This is relevant to what Harvard McLean Hospital in the US is doing in order to plan for a 20-bed facility and the outpatient, these 20 beds. The whole of people who are developing service are talking about full-time equivalent. And the full-time equivalent means a person, a nurse, a doctor, or a psychologist, how many patients they should care for at one single day, either individual or in a group. And there is a key person who is the case manager, who can take 3 to 4 cases, because he is liaising these patients for them day and night. So 4 is a number. So the calculation of full-time equivalent, that is equation, includes the days of work, the hours of work, and also the vacation. So in some countries they work only 220 days, other countries are working more than that because of the vacation, the weekends, and so. So the calculation, the equation came like that. By the end, you will find for 2 beds, 20 beds, about 43 persons of different subspecialty is needed. How many persons you have, Dr. Heba, in the hospital here? 20? Right, so that is how an ideal workforce to care for the patient. And not only for the patient and the delivery stage of where the patient is, and also to his community or family and communities. And the calculation and the full-time equivalent is cited below. So this is a slide that we have to look at. We have to look at salary. What kind of professional and paraprofessional are needed to do that? So we move to the system conceptual model. Now, in short of all this slide, the treatment should be available, accessible, affordable, and evidence-based and diversified. Not a one-size-fits-all. And I will show to you how this can be achieved. Now, places in our countries where primary care and public health care system is to deliver the service to the patient, whether they are hospital, clinics, family practice, internal medicine, nurses, others. Some other hospitals, or the substance abuse services in particular. For example, in Egypt, there is the Addiction Trust Fund, and they are deploying places all over the Egypt for substance abuse and their comorbidities in liaison with psychiatry at that area in Egypt. So there are now special services. Other countries that I had the privilege to work in, they have their own addiction services. But now they are declining this, and they are integrating the addiction service into the mainstream of health. So with all the the success, but it is very, very demanding and expensive, and then they put it within the health system. But also social services is very essential and needed. So these are what we call a segregated system. Like, what is the disadvantage of the segregated system? If I have a patient and this patient is developing psychosis or some medical problem, and I need to refer this patient from the very specialized clinic or hospital to mental hospital or general hospital or surgery, most probably this patient will fall between the cracks of the referral. He will drop out. And for him or her, it's better to resume the habit again, more than waiting list and waiting for another patient or waiting for the doctor to see him in hours if he could find an appointment. So that is a major disadvantage. And the cross-discipline training is very poor. You go to a neurologist, he'll prescribe tramadol because this patient have pain. Or you go to a pain clinic, they prescribe tramadol while the patient is opioid dependent because there is no kind of common network, so we serve the patient the best way. So that is another one. Expensive and inefficient. High proportion of prisoners, we all know, have problem of substance use in prison. So the current effort to reduce this in many countries, I'm not talking about Egypt, I'm talking worldwide, is to increase screening and the intervention in primary health care. So the move to have an evidence-based result should be in our hand, which is the screening, develop dual diagnosis services, integrate infection services or especially blood-borne disease within the system of management, increase linkage between social services and substance abuse care, and blend the funding stream. Money is most important and most determining factor in our region. Now, if you are to make a decision, likely effectiveness and intervention, intervention relative effective in a different interventions, where likely effect of modifier, what can block our movement, and resources needed to overcome this diverse. Talking about the evidence-based, the most evidence-based in our profession is the use of opioid-assisted treatment, methadone and buprenorphine, and both methadone and buprenorphine have goods and cons and pros. Methadone can be diverted easily, but it is cheaper, evidence-based, all researches on methadone all over the world. But buprenorphine, the only disadvantage that I can say, it is expensive. But this is an evidence-based. Now, the service integration of co-occurrent diagnoses can be defined the process of providing services of two illnesses for addiction together, and the integration can range from single provider to effort of comprehensive program like a university like this, or complete services integration require consideration and responses to one, the needs, the problems, that means what kind of population that you are serving, and issue across services, so we are not duplicating. For example, if Dr. Tamer and Dr. Heba, they have a service for substance abuse, should they in the Psychiatry and Addiction Hospital in Cairo University, should they do an intensive care unit? Who said yes and who said no? Okay. How frequent in your services you receive an overdose?
Very frequent. Very frequent.
Just raise your hand if you receive an overdose. Okay, how frequent? Every day? Every week? I can see only 3 hands. Okay, every month? Okay, so do we have to have an intensivist and no, intensivist, doctor and nurse, and ICU specialists, monitors, while I have 4 or 6 intensive care units within 100 meters around me. Listen, I can resuscitate, I can hide intermediate care, but if I have access, this is one. This is this hospital. What about a small remote area? Is it a requirement? So we need to integrate. We need to integrate. I'm not going to, these are the intervention in different level system that I was trying to explain for you. The informal community care, where perhaps the outreach interventions are there, the primary health care, the generic social welfare, the specialized care, the other specialized services, and so on and so forth. And each column here have the description what should be there. So the system requirements, definitely planning. It needs financing. Needs more monitoring and regulations. But if you go from here, it's easy to look at it. There is policies for that. There are system characteristics for that. We measure the effectiveness, and by the end, the population impact. So we need to see who that we are giving this service and the impact. And there are lots of measurement for that, pre and post, that we can measure and see the effectiveness of the service that we are providing. Now, this is looks very complicated, but it summarizes what we are saying. These are processes, number of processes, how we can build services. When I pose the question, should we have an intensive care in each facility? The response is here. It depends on what type of facility that you are catering. Primary health care provider, perhaps a nurse there. You cannot do intensive care in a village or a remote area or in one of our countries, in Uganda, in Nigeria, in Kenya, in Egypt. That is not cost effective, and it will not even serve a patient, that we cannot find the professional enough to run these services. So these are there are the withdrawal, there are the community, and there are the aftercare service, and there are levels for that. If we have this component of this level, then it is feasible to start doing and cater for such a service. What is the concept of the service model? If you can see, most of the people have been treated. This is one of the slides of the Atlas of substance abuse. Mostly they are specialized treatment service. The one here in that color, the brown color, the light brown, and then general health service, mental health services. These are what we have all over the world. Now, we are in Egypt, so we have to have pyramids. So now that is the quantity of service needed. At the bottom is the self-care. If we go to the left column here, which is the cost is the right column, but the property of frequency of care on the left. Whenever the frequency go up, that means that this patient needs more sophisticated care. And the down, the two blue, darker blue down, it is the care that most of our countries in Egypt or in Africa help and serve the people. Finally, this is the recovery-oriented management and care. It all runs after what we call the spirit, which is the screening, brief intervention, referral to other relative services. That is a basic unit for any addiction services, either in a remote area, in a clinic or primary care health services, or even in the hospital. You have to have a triaging. You have to find a way of how to assess this patient and refer this patient, or retain this patient and manage, or refer to more highly specialized services, and then when they finish giving the service, they refer back to you and you take care of it. So there are levels of services. You should not have all one same system of services, but there are levels of service, but the basic competency are the same for doctors, for nurses, for psychologists, social worker, and the allied group. And this explains the health services and the model in the community-based in details. So there are mental health services, there are general health, there are clinics, and the stakeholders, how they can, and the rehabilitation services, and the care management, and the content of the care management, how to identify, how to screen, how to refer, how to manage it looks like a kind of a jungle of information, but look at your practice. Actually, we are doing this, but it needs to be more organized, more integrated with your living community and how to manage it. We cannot alone manage the patient. We need the cohesiveness of the society, the cohesiveness of the law enforcement, the cohesiveness of other more specialized services. These are the leading list. That is, I quoted most of my lecture from. I hope this was not very much boring to you, but you are doing each and every one of these, and thank you very much.
Thank you, Dr. Tremendous job. It's very hard where to start from. And now, I don't know whether the floor had any comment or any question before we end. Thank you very much. Thank you.